So, good morning, everybody. Thank you for coming again in this rainy day, ugly day. This is the last press release for the ILC and will be dedicated to hepatocellular carcinoma and fatty liver. As you know, the data today have been selected according to the implications for clinicians and patient real life, so to be maybe not immediately, but almost ready for using clinical practice because of the scientific value and groundbreaking research. I would like to remind you that today's data slides have been provided directly by the authors. Some of the authors are in the audience and will probably be able to answer to your questions if you have specific issues. Today we will have two presentations. The first one will be provided by Professor Marco Speck, who is the EASL Vice Secretary, and he will present new developments in the area of HCC, and specifically studies showing how exercise could reduce the development of liver tumors, a new diagnostic tool that hopefully will help physicians to determine whether local regional treatment, with a specific treatment for hepatocellular carcinoma, is the best option for patients. If a COX-2 inhibitor may reduce the recurrence of hepatocellular carcinoma after surgery, and also a study aimed at identifying nucleotide polymorphism to predict HCV-related liver cancer development in Caucasians. The second presentation will be given by Professor François Dufour, who is an EASL educational counselor. He will present data about fatty liver, and he will present data specifically showing how fatty liver increases the risk of atherosclerosis independently of other patients' cardiovascular risk factors. And we'll also speak about two new non-invasive tests that benchmark survival rates and cardiovascular deaths for patients with diabetes and metabolic risk factors without known liver disease. And in the end, we will have closing remarks by Marcos, who will be next year the new Secretary General for EASL. So it's my pleasure now to call Marcos to the podium.
Daniele, thank you very much. Ladies and gentlemen, thank you very much for coming here already the third day in a row to this press conference about topics that we think are of interest to the general public from our meeting here. So today we're talking about HCC treatment decisions giving hope to cure to patients. And as you probably realize, there is no large phase 3 trials presented here at this meeting. The HCC field is actually moving at a quite interesting pace, but this year and at this point in time, none of the trials are finished, and the ones that are finished have already been presented. So we start out with a work in an animal model, effect of regular training on hepatocellular carcinoma development in hepatocyte-specific P10 deficient mice from Anne-Christine Piguet, and actually it's the group from Jean-François Dufour. As you know, the Swiss people are very great sportsmen, regular competitors with us Austrians in the skiing world championship. And they're also very meticulous. So if you're a Swiss mouse, you have to go on training. And that's what Jean-François did here. So the question was really, is regular exercise affecting development of HCC in a mouse model of non-alcoholic fatty liver disease? So what they did is they had two groups of mice, ones that were just happy and eating regularly, and the other ones, they had to exercise. And as you can see here, and below here, that there was a treadmill specifically designed for mice. You know, quite a funny device, where they can actually race against each other. So that they also, of course, before your race, you have to go through some training periods, so they could do some exercise for the first 2 weeks to get used to the treadmill, and then they would run an hour, 5 days in 7 days, and in the end, all were killed. And then they looked at the livers, and what you could see here is quite interesting. Such as in the mice that were exercised, you got a significant reduction in the development of tumors, which otherwise this model develops with certainty. You know, in the control mice, 100% developed a tumor, and the other ones only 70%. And also, when you look at the number of nodules, you can see there was a much larger number of tumor nodules in the mice that did not exercise, and the volume of the tumor, meaning the size of the tumor, was much higher in the mice that did not exercise as opposed to the ones that did. So this is actually a very important work, hinting at studies that should be done also in humans to look at whether a more active lifestyle with regular exercise would be able to reduce the incidence of non-alcoholic fatty liver disease and one of its most severe consequences, liver cancer. The next trial is one of 2 trials that we're presenting here on a technique that's more and more getting interest in the treatment of HCC, and this is radioembolization, also called systemic internal radiation therapy with yttrium-90. And there have been several reports on this treatment, including a European multi-center collection of data. And this is a technique where you embolize the tumor from within, inside, like transarterial chemoembolization, just with smaller particles that emit radiation and inflict radiation injury or destruction to the tumor. Now, as with all these treatments, of course, you know, first you develop them, you do some series, and then you have to mature and have to look where the place of this treatment could be, and that you do usually in randomized controlled trials. So here, this is first a pilot trial, randomized trial of intermediate stage liver cancer patients getting either transarterial chemoembolization, which is the standard of care, as you can see here, and the other group being randomized to SIRT with yttrium-90, which is the novel treatment. And you can see there's some inherent differences. I mean, both are intraarterial therapies, but TACE you have to apply repeatedly, while SIRT you usually apply just once, and then the follow-up was done. And it was a small sample, as I said, pilot trial. But what you can see here is the progression-free survival. Statistically, there was no difference between these 2 treatments. And of course, overall survival data we don't have. It would also not be very meaningful with this small patient group. But what the authors could see here is that SIRT is safe and effective, single SIRT as opposed to multiple TACE sessions. There were no difference regarding quality of life, progression-free survival, and severe adverse events. And the results, in my opinion, show that it would be very reasonable and timely to have a large phase 3 study conducted to compare these 2 treatments in patients with intermediate HCC to really show where the place of this treatment could be. Another thing also dealing with intermediate stage HCC patients undergoing transarterial chemoembolization, is the problem that these patients, some of them are doing quite well with these treatments and others are not doing well at all. And the problem is that when you do a transarterial treatment, you block the arterial blood supply to the liver, and that kills the tumor, but is also not always good for the liver. So what you see if you're treating those patients is that some have very, very, very long survival, while others, where you think these patients are in quite good condition, deteriorate very fast after this kind of treatment. And the outline of this study here which was actually conducted by my group, was to find a predictor before the second treatment, whether you would go on with this treatment or whether you should stop it. Now, the way this was done is patients with the appropriate tumor stage, BCLC stage B, would have a first TACE, and then before the second TACE, we were looking at all kinds of predictors or factors which we entered in a multivariate analysis to find out whether they would correlate with the outcome after that. Then patients would undergo a second TACE, oftentimes also a third and a fourth TACE, and in the end we would look for overall survival. And we would do that in our patients and have it validated with an independent patient sample from a different institution. So what you can see here, that by having a simple score consisting of 3 parameters, which is the radiologic response, the change in AST, and the change in Child-Pugh, we would assign points to this, and if you distinguish between those with high and low points, 0 to 1.5 points versus more than 2.5 points, you would get very different survival in these 2 cohorts, which you can see here, 23 months versus 6.6 months. So you can stratify very well different prognostic groups. This is the training cohort, this is the validation cohort. You can see very nicely that this was also valid in an independent patient sample, which gives you some confidence. This is just not an incidental finding, but this is really true. And this is how we assign the points. The radiologic response gives you 1 point. If there's none, if there's an increase in AST, more than 25%, you get 4 points. If there's a Child-Pugh increase, you get 1.5 points. If it's an increase by 1 point, if it's more than 2 points, you get 3 points. So what the strategy now is that we propose is that you have the patients in the appropriate stage, give them a first TACE, you do the score. If these patients have a low score, you retreat those with transarterial chemoembolization as needed, while if your patients have an elevated score, you will have to look for alternative treatment strategies, and this is now a matter of discussion and actually a matter of clinical studies to show what we should do with these patients here. The other abstract dealing with yttrium-90 radioembolization is this interim analysis here from a trial called Ceramic. Ceramic is a multinational European trial that is actually in its outline a more complex trial, but the abstract that's presented here at ILC just deals with this group here called palliative arm, where patients with advanced stage HCC, intermediate stage or intermediate to advanced stage HCC are randomized into a sorafenib group or into a yttrium-90 radioembolization plus sorafenib group. And the question here is, does the addition of yttrium-90 radioembolization to treatment with sorafenib give you an added benefit? And the abstract that's presented here deals with the safety aspects of this treatment, because if you do an additional treatment, you could also, of course, have additional side effects. And these are the first 100 patients that were entered into the trial, and this is a very busy slide, but I just would like to direct your attention to this column here as well as this column here. And if you go through it by and by, you will realize that the adverse events in the combination group versus the sorafenib monotherapy group really show no difference. First of all, there's a very low frequency of grade 4 or 5 adverse events overall. There's some grade 3 adverse events, and if you compare the two groups, there's really no difference between these two groups, which indicating that the combination of radioembolization with sorafenib treatment is, at least from a safety point of view, very well tolerated, and the efficacy we will see only in probably 2 years, I would say. Here's another trial in early stage HCC, a Japanese trial, randomized controlled trial, which looks at basically at secondary prevention of hepatocellular carcinoma. This trial was conducted in over 230 patients, early stage patients that underwent either resection or microwave ablation of early stage HCC. And then these patients were randomized to receive either a COX-2 inhibitor, meloxicam, or placebo. And as you can see here, this is the flow chart of the trial, the meloxicam group and the placebo group. But then to understand the data, you'll have to see that the authors then looked at this not at an ITT basis. They looked at it at an ITT basis, but the results were not significant. And then they looked at the group that really received meloxicam, the true meloxicam group, as opposed to the ones that discontinued. And then they had the true control group, which did not receive any treatment because some patients did receive the drug after the randomized phase of the trial. So the overall findings here were that if you look only at the really treated patients, you would see no difference in the overall survival between these patient groups. But if you would look in the good patients, the Child-Pugh-A patients, and those are the ones that really, of course, derive the most benefit from an adjuvant treatment, you can see that the true meloxicam group showed a significant lower rate of recurrence than the true control group, indicating that treatment with something that's a COX-2 inhibitor, a drug that is not very toxic, is not very expensive, could really prevent the recurrence of HCC, at least in this group of Japanese patients, which were mostly hepatitis C-associated liver cancer patients. So with this, I want to hand over to Jean-François.
So effectively, I'm one of the two educational counselors of the EASL governing board. I have no disclosure in terms of relationship with the industry, but I am investigator in this FLIP consortium. This is an EU-funded consortium to do research on non-alcoholic fatty liver. I'm one of the investigators. I mentioned that. So because some of the two studies I will present to you are derived from other investigators. So for those of you who went to the state of the art, which is just finishing now, that was about non-alcoholic fatty liver disease. And Chris, they really emphasize that this is a very frequent disease. It's the most frequent disease, actually. Condition, we should say, about 40% of individuals have fat in their liver. And we know that for some individuals, this is associated with a shorter survival. And so the two papers I would like to present to you are from the group of 20 Poignard in Paris, and they refine the association or the knowledge that we have about the association of NAFLD with cardiovascular events, cardiovascular death. So the first is increased prevalence of NAFLD in patients at high risk for cardiovascular events and correlation with early predictors of atherosclerosis. So we already know that non-alcoholic fatty liver is tightly associated with diabetes, with obesity, and that these patients are at risk for cardiovascular events. So what they did here is that they assess the impact of NAFLD on early markers of atherosclerosis, and they measure that by measuring ultrasonographically the intima media thickness, IMT, in the carotid, and they also measure the carotid plaques. They evaluate the 10-year cardiovascular risk with a validated score, which is the Framingham risk score. And they have a study population that you will see is quite large, which is defined by at least 2 cardiovascular risk factors. 2 of these could be high blood pressure, diabetes or high fasting glucose, dyslipidemia, obesity, or tobacco. And this patient, there is available carotid ultrasound with measurement of carotid intima media thickness and carotid plaques. The consumption of alcohol should be less than 50 grams a day. They exclude other causes of chronic liver disease. And they defined NAFLD based on a score which has been validated, which is a fatty liver index, which is based on certain parameters that you measure in the blood. And the first observation in this study with nearly 6,000 individuals is that you have NAFLD in 40 of them. So this is very prevalent. And then they look at the association with atherosclerosis. And the prevalence of carotid plaques is higher in the patients who have NAFLD in comparison to the patients who do not have NAFLD. Since they are dealing with a large number of individuals, these differences from 29% to 26% is highly significant. And looking at the cardiovascular, or actually the coronary risk score derived from the Framingham risk score, they find here also that the patients with NAFLD, defined by the fatty liver index higher than 60, have a higher score than the one without NAFLD. And these associations, these two associations, are actually independent statistically. So these work illustrate that NAFLD is highly prevalent in patients at high risk for cardiovascular disease, and also that NAFLD is an independent, and it is what he knew, independent predictor of early atherosclerosis and 10-year Framingham risk score beyond classical cardiovascular, other risks. So this is for the first study from this group, and we would like also to highlight a second one which has been presented yesterday. We are in need to identify patients at risk to develop complication when they have NAFLD. I mean, with a condition which concerns 40% of the population, it's very important that we can identify who should be controlled more frequently, who are at risk to develop complications. And so here, in this work entitled 10 Years Prognostic Value of Fibro Test and Steatotest for Liver-Related and Cardiovascular Death in patients with type 2 diabetes and who have hyperlipidemia, is what they did with these two non-invasive tests. So the aim was to evaluate the 10-year prognostic value of these two tests in patients with diabetes and who hyperlipidemia, regarding which is the hardest endpoint in medicine, overall survival, and also survival without liver-related death and survival without cardiovascular death. So this is the main observation of this work, is that in these patients, and again, this is a large collective of patients, more than 2,000, the patients who have a fibro test predicting that they have fibrosis in the liver have a survival which is significantly lower than the patients with a fibro test predicting that they don't have fibrosis or practically no fibrosis in the liver. These differences at 10 years is very significant. So here we have a tool which allows to identify which are the patients at risk to develop complications. Now looking at not the overall survival, but the survival without liver-related death, they also observed a significant differences in survival if this test was associated with fibrosis or no fibrosis. They refined further the analysis regarding the other test, which is the steatotest. Here it is, in patients with hyperlipidemia. And they found here that there was an effect smaller than for the fibro test on the survival without cardiovascular deaths in patients with hyperlipidemia. So what I wanted to show you here is that in these populations, in diabetics, regardless of hyperlipidemia, the fibro test has a significant 10 years prognostic value for overall survival and for the survival without liver-related death. In a further analysis, they report that in hyperlipidemia patients, the other test, predicting steatosis, STEAT2 test, was helpful to identify patients who will have a lower survival, not due to cardiovascular death. So these two papers, which are presented during this meeting, illustrate, one, that NAFLD increases the risk of early atherosclerosis lesions independently of well-known cardiovascular risk factors, and that two non-invasive tests allow to benchmark survival rates and cardiovascular death in patients with diabetes and or dyslipidemia. The fibro test for the overall survival and the survival without liver-related death at 10 years, a long survival, a long time, a long follow-up. And the STEAT2 test was predictive for the 10-year survival of unrelated cardiovascular death. Thank you.